Good morning, everyone. I hope you're enjoying your Easter holidays. I'm Solomon Kanyago, a level 5 medical student at the University of Nairobi. And welcome all to XYZZ Med. It's a place where Kenyan medical students come together to shake up the world of medical education. It's a vibrant student-led community from universities across the country. They're all united with one big mission, is to make medical learning more local, more relatable, and a whole lot more exciting. So a lot of our medical education leans heavily on foreign materials that don't always fit our Kenyan healthcare realities. That means future doctors and health professionals aren't always getting the full picture when it comes to local diseases, patient experiences, or even how best to communicate with communities we serve. So to cater for this gap, we come here to change that. So XYZZ Med is creating a cool, accessible, and Kenyan relevant resources like medical illustrations you can actually relate to real life case simulation, quizzes, mini lectures like this one, storytelling, research, and other interactive learning tools, all designed by students for students. And today's CME is part of that exciting journey. So this series is all about peer-to-peer learning because let's face it, sometimes your classmates explain the tricky concepts way better than the textbook or even the lecturer could do. So without further ado, we want to dive into today's session. And our speaker is Tanvi Patel, who is a level 5 medical student at the University of Nairobi. And we can welcome her so she can proceed with the session. So today we'll be doing our OSCEs on Obs OSCE as we prepare for examinations. Welcome, Tanvi.
Thank you, Solomon, for the lovely introduction. My name is Tanvi Patel. As you said, I'm a fifth-year medical student. Today, a comprehensive revision of obstetric skills and emergency scenarios, as well as we will do some practice questions at the end. So let me get right to it. If you can please confirm if you can see my screen.
Yes, we can.
Perfect. So today's presentation will be going through all the skills scenarios that we learned. And at the end, we'll go through some practice questions. Just a second. Is it on slideshow?
Not yet.
Not yet? Okay, just a second. All right, perfect. So the objectives for today's is we'll be starting off with the basic examinations. When a patient walks in, what do? You have your sterile speculum examinations and you have the DVE, our digital vaginal examination. Moving on to that, what are some of the investigations that we do? We do CTGs. So we're going to be talking about CTGs, how we do them, and then interpreting them. The next part is we'll be talking about deliveries. Our normal vaginal delivery, what happens in a scenario where you need some assist? So an assisted vaginal delivery, in our case, we normally do vacuum and KNH. So we'll be focusing on that. And the next will be in mouth presentation. So what happens in a scenario of a breech delivery? The next one we'll be talking about what goes wrong. What are possible things that can go wrong in a delivery? You can have shoulder dystocia, you can have perineal tears, and you can have something as PPH, which we all know we've talked about multiple times. And I understand we've also had a session prior, so this will be a nice revision on it. So getting on, we start with our first one, sterile speculum examination. For you to know how to do it, you need to first know your equipment. So starting off, what do we need? We need our antiseptic solution. In this case, we always use Hibitin, which is most commonly used even in KNH. The next thing we need is sterile gauze, 5 sterile gauze because we do the 5 swab technique. And otherwise, we call it pack 1. You must have heard that if you're in the wards or in labor ward especially. The next thing we need is lubricant gel, which is KY gel. In our scenario, we normally have KY gel available. In a rare situation where it's not, ideally, then use normal saline, but it's not recommended. It's better to always have KY gel. The next thing is sterile gloves. Make sure you have that in your size. Followed by it, our bivalved speculum, the equipment that's needed. Now, Speculum comes normally in two shapes. There is the couscous and the graves. The difference is not much. It's mostly in the hinge and the shape of the blades. Ideally, we use couscous because it has a shorter blade and it's curved. So it gives us a better view of the cervix. Graves is more longer and straight blades. It depends normally what is available, to be honest, in KNH. And in some private facilities, you'll also now see the plastic ones, which are a bit easier, and those are use and throw. Examination, you need to understand when to do it, and you also need to understand why you're going to be doing it. So when do we do it? With signs of PROM, or when you're suspecting PROM, and in some other rare scenarios. Why do we do it when someone is presenting with bleeding? Because you want to know if this patient is having a miscarriage or an abortion. So why? When you do the speculum examination, you'll know if there's any cervical dilatation. It will also help you classify the type of abortion that you have. It also helps to rule out if there's something like polyps or ectropion, as ectropion can cause bleeding, but in pregnancy, as we know, it can be physiological. In other scenarios, when you're suspecting PROM, which is a premature rupture of membranes, why do we do it? So that we can see again if there's any dilatation, effacement, any pooling of amniotic fluid at the vaginal vault. Why? This will help us to do our test, Fanning test or the nitrogen test to confirm this diagnosis. In other scenarios, which is not much, is when you have discharge or you're suspecting of an infection, then you go in to do a swab to find culture and give the right antibiotics. How do we do the examination? All examinations start with the hi and end with the bye, okay? Start by introducing yourself. Explain who you are, what you're doing, why you're doing it, and make the patient feel comfortable. Number two, explain the entire procedure thoroughly about exactly what you're going to do, why we're going to do it, the importance of it, and obtain consent. Consent is very important. Make sure you do it because you don't want to get sued down the line. A verbal consent is mostly done in these cases. Number three, find an examination room. Privacy is key. You want to feel comfortable. You want the patient to feel comfortable when doing this. Okay, so get a private room or at least have the curtains drawn in our case. Yeah, and get a chaperone if you're a male. Very important. Next, get all your equipment ready. You don't want to start doing it and then be like, oh, I don't have this. I need to go look for this. That doesn't work. Yeah. Step number four, ask your patient to go pass urine. Ask them to empty the bladder. It's important. It makes them feel comfortable throughout the exam. It makes the exam a little bit more easier for them to do, yeah? And for us to do it, you're less likely to injure the bladder. Privacy, and then tell them to lie in lithotomy position. Or if they are well into the pregnancy and they can't really prop their legs up, you can ask them to lie on their back with the legs bent at the hip and then just flop the knees apart. Additionally, provide a drape for comfort to help them give a little bit of cover, yeah? Number five, prepare your instruments. So remove your packing or everything, put your gloves ready, adjust the lighting, and then start by washing your hands. You wash your hands using the 10-step protocol. Next, wear your gloves in a sterile manner. Number six, report your findings, and upon inspection, you talk about your external genitalia. You're doing this before you wipe before you wipe. So you're talking about any characteristics, what the hair distribution is. Is there an enlarged clitoris? Are you seeing any skin abnormalities? Are there lesions, warts? Is there a discharge? If there is a discharge, what is the color of this discharge? Does it have a smell? What is the consistency? If this person is bleeding, what is the color of the blood? Are there clots? Is it active bleeding? If it's swelling, what is any swellings? Describe the size of it, where exactly the swelling is located. You can even ask the patient to cough so that you can see if there's any incontinence or prolapse. Once you've done your inspection, like all examinations, now you move to the next part, which will involve the vulvar toilet. In this, you're going to be doing the 5 swab technique. Very important. If you're standing on the side of the patient, how are you going to do this? You're going to start with the labia majora, that's the furthest, then come to the majora, that's the nearest. Next, you go to the minora, that's the furthest, followed by the minora, that's the nearest. And then you end with one, which is straight down. Once you've done that, lubricate your speculum. Using your non-dominant hand, part the majora and gently insert the speculum in. Now, according to this, there are 2 ways of doing this. You can either go with the blades in vertically and then rotate the speculum, or you can go in straight from the start, go in horizontally. The method depends on you. I've seen in KNH, both are used, and they say If you go vertically and then turn it, there's a chance that if there's polyp, you might cause bleeding. However, if you have a speculum that's of a very big size compared to the one that should be used, you might want to go in vertically. It reduces the trauma. It makes it a bit easier. Once you've done with that, use your light to guide you and find the cervix. Once you're in, tighten the screw and lock your speculum in place. Again, now what you do, you start with report. Report what you find. Start with the walls, describe what you're seeing, if you're seeing any lesions, if you're seeing bleeding, then move on to the cervix. In the cervix, what do you want to know? You want to know if there's any dilatation. What is the position of this cervix? Are you seeing any defects? Are you seeing any abdominal discharge? If there is discharge, what is the color of this discharge? If you're seeing any bleeding, you can even ask the patient to cough to see if there's any active bleeding. Is there polyps? Isn't there an ectropion? So basically, you're doing everything to find out and diagnose this patient. Yeah. Next, since you've made this patient already uncomfortable, you might as well take a swab. So do an endocervical swab, especially when you're seeing blood, discharge, or fluid. Because you don't want them to do, then suspect, then tell them, oh, we need to do another speculum examination to get some samples. Next, unlock. Do not close the blades. Do not close the blades. Leave the blades open. Come out with them open and gently remove. Why? Because you close the blades, there's a very high likelihood you'll take some tissue in and cause a lot of more trauma as you come out. Number 12, always clean. Say thank you to the patient, document your findings, send your samples to the lab, and always update the patient on what you found. So start with a high, end with a bye. Step number 2, another examination that is normally done is the digital vaginal examination. Again, it is a sterile procedure. When do we do it? Ideally, you don't want to keep doing it because there's a very high risk you're going to have the patient get an infection. So you only do it when necessary. And when is that? When you want to assess a patient between contractions, i.e. you're filling that partograph. Or when you have no inadequate contractions and you want to see what's the progress of this labor, okay? So how do we do it? The first 6 steps remain the same. Start by introduction, explain the procedure, why you're going to do it, get consent. If you're a male, get a chaperone, get your equipment ready. In this case, the only things you need is your sterile gloves, KY gel, Hibitin, and the swabs. Ask the patient to again pass urine, to lie down in a supine position with their legs bent at the hips, and they can flop their knees apart, give them a drape, and then report your inspection of the external genitalia. Step number 7 is where it gets different. In this case, now what you're going to do is you're going to lubricate 2 fingers of your dominant hand, which is going to be your index finger and your middle finger. Use your non-dominant hand again to spread the majora, and you gently insert the fingers in, and you tell the patient what you're doing as you're doing it. Be like, now I'll be inserting my fingers. You might feel a little bit uncomfortable. You can ask the patient to breathe in and out or try to distract them. Step number 8, palpate the walls. You're feeling for any temperature, any masses, any lesions. Next, you go to the cervix. Now, here's a mnemonic. It helps to remember what you're looking for in the cervix. So just remember, please cook every delicious dish happily. So please is for the position, C for consistency, E for the effacement, D for dilatation, again, D for descent, and H for the head position. You're basically doing a Bishop score. You want to know how, we're doing this in labor, so you want to know what is the progress of the labor. You want to score this patient. So basically, just remember this mnemonic. Please cook every delicious dish happily. Yeah. Step number 10, assess if there's any prolapsed umbilical cord. Once you're done, remove the fingers. Do not throw the gloves. Inspect your gloves. See what is the color, what is the consistency. If there's any smell, describe that and put that down in your findings once you're documenting. After you've noted that down, dispose of your gloves, thank the patient, and again, always document your findings, update the patient. Again, start with the high, end with the bye. Number 3, moving on to CTG or cardiotocography, or sometimes it's also referred to as fetal heart rate tracing. So we've all probably seen this in labor ward. We've probably all seen this in labor ward, right? This is the LCD display. I don't think I've seen any questions where they've asked you to name the parts of this, but it's always good to know. So you can go through this afterwards. This is what we're concerned with, the transducers and the elastic belt, okay? So what is a CTG? It is used to monitor the fetal heart rate and uterine contractions. It's a graphical display of the fetal heart rate with or without contractions. And it's most commonly used in the 3rd trimester. Why do we do it? We're doing this to monitor the fetal well-being and allow for early detection of fetal distress. Or when you want to monitor the fetal heart rate in relation to uterine contractions. When do you do it? When you're suspecting that there's a non-reassuring fetal status. When you have a patient that comes in, complains that, oh, since the last 12 hours, I have not felt in my baby kicking. There's been no movement. So you're suspecting of reduced fetal movement. Next, in situations of IUGR, where there's intrauterine growth restrictions or certain maternal indications, GDM, preeclampsia, or she's a mom who has a cardiac disease, or she's had seizures. You want to know the status of this baby. So there are two types of the CTGs. There is the non-stress test and there is CST. So NST, non-stress test, it's in the name. There is no stress. In labor, the stress is contractions. So it's basically you monitoring the fetal heart rate in the absence of contractions. It's normally done antenatally, and this is not done in labor, because when you're in labor, you're doing a CST. You're checking the fetal heart rate with contractions. That's what CST. So CST, contraction stress test. You're doing it when there's stress, when there's contractions. The steps of doing this is very simple. You just apply some gel onto the probe, do a Leopold's maneuver and find out where the fetal back is. Put one probe there, we'll put one probe on the other side, and then secure it with an elastic belt, which is this. The next one. So again, when you're decoding this and trying to understand the graph and understand this, there's a mnemonic that comes in handy called Dr. C. Bravado. I'm sure everyone has heard of this. So we'll be using it today's session to understand this. So this is the second mnemonic for today. Yeah. The first one, doctor, you don't separate doctor. It's always together, right? So DR stands for definite risk. This has nothing to do with the CTG. It's based on the history of this patient. You want to know whether this patient is a high risk or a low risk patient. Why? Because it will guide you in your intervention as you come towards the end. There are certain complications which make a pregnancy high risk, such as maternal complications like GDM, preeclampsia, asthma, HIV, anything that has chances of increased mortality and morbidity to this mom because of in this pregnancy. Other obstetric complications, they could be multiple gestations, trial of labor after a CS. Again, in IUGR, you're suspecting there's premature rupture of membranes, this macrosomia baby. So anything that can make this delivery harder is a high risk, yeah? Other risk factors can include any use of substances, if there's any use of medication such as epidural, if this is a mom that has smoked and drinks alcohol, or lack of ANC. Because if there's no ANC, you don't know how to progress in this pregnancy. You don't know how to help because you have no history, no background that you're working with. Next are your contractions. So C stands for contractions. In this, you're basically recording the number of contractions in a 10-minute period. To understand a 10-minute period, you need to know in a CTG what it looks like. Ideally, one small box, this box is 1 minute. So 10 is equals to 10 minutes. Sometimes it's a tinier box for 1 minute. So either way, one small box is 1 minute. So 10 boxes will be 10 minutes. What are we checking in the contractions? You're checking for two things. The number one will be the frequency of the contraction, i.e. you want to know the number of contractions in a period of 10 minutes. And the next thing you do is the duration of the contraction. But the most important one is the frequency. So ideally in labor, which is like active phase of labor, when you will normally, the normal range is about less than or equal to 5 in 10 minutes. Anything that is greater than equal to 5 in 10 minutes, there is hyperstimulation or what we call tachysystole. This is important because it might change your intervention for this mom. This is a graph to help understand the difference. If we look over here, and if you count 10 boxes over here, yeah? If you can zoom in, or I think if you're on your phones, you'll be able to see that in a period of 10 minutes, we have 2 contractions, which is normal. We said anything less than or equal to 5. If we look at the graph at the bottom over here, we can clearly see, even if we don't count, that we have way more than 5 in a 10-minute window. So we're looking at hyperstimulation or tachysystole in this case. This is for you to just identify, see graphically what the difference between both will look like. Yeah. The next one, baseline rate. So what is the baseline rate? It is the average heart rate of the fetus within a 10-minute window. You're looking at a CTG to assess the average heart rate that has been over the last 10 minutes. You ignore any accelerations or decelerations. If you remember in biochem, when we used to draw the lines on the graph, you make an average. You leave a few up, few down, and you draw that average line in between. That's basically it. The normal fetal heart rate ranges from 110 to 160 beats per minute. Anything that is greater than that is tachycardia. Anything less than that is bradycardia. The increase or a decrease in a heart rate that lasts longer for 10 minutes will change its baseline heart rate. Here we have another example to just understand it. I've drawn this line so that we can look at the average. Again, we said we're ignoring any of the accelerations or decelerations. And then if we take an average of the remaining, we can see that it comes to 120 beats per minute, which is normal. Now we have two figures over here. Again, if we look at the first one, and if we draw an average over here in between, we would find that the average heart rate would come to at around 175 beats per minute. 175 greater than 160, we're looking at tachycardia. If we look at the graph at the bottom over here, ignore the accelerations. And if we draw an average, for example, even in this 10-minute window over here, we can see that the average heart rate comes to around 90 or 95 beats per minute, which is less than 110. So we're looking at bradycardia in this scenario. So this is just a table to help understand the different causes that can be as a result. Why are you seeing this different graph? So what are the possible causes? So we said again, tachycardia is anything greater than 160 beats per minute. What does it indicate? It normally indicates that there's fetal distress or there are signs there's an infection. So why is it important? It's always important in these cases to also take the maternal temperature. You want to rule out chorioamnionitis. So the temperature is very important. Some of the other causes include drugs. If the mom is on any sympathomimetics or regulatics, it can also present such a way in the graph. Infection, both maternal and fetal, especially chorioamnionitis. If you're suspecting anemia, and in some cases, chronic hypoxia can also cause tachycardia. What about bradycardia? We said bradycardia is less than 110 beats per minute. Ideally, it's not very concerning when it's just around 100 to 120, because it could be just a sign that this is a post-date gestation. So it could be anything great. If it's a pregnancy that's gone beyond 41 weeks, it may present as that. Or if there is a change in the position of the baby, this baby is in occiput posterior or in a transverse position, they may present with bradycardia. However, in some cases, you need to take it a little bit seriously if it's continuously. Why? Because it could be a sign of hypoxia. It could be an early sign of hypoxia. It could be a sign that there's prolonged cord occlusion, there's sepsis, maybe there's a heart defect that's causing it. Sometimes medications to the mom, such as the epidural, can cause also bradycardia. MGSO4, supine position, and all the hypos, hypothermia, hypoglycemia, hypotension. What about severe bradycardia? Anything less than 80 beats per minute is now, or more than 3 minutes, is now classified as severe bradycardia. This is an emergency situation because this would suggest that the baby has severe hypoxia, there's cord prolapse, there's prolonged cord compression, and you need to intervene. The next thing, V, for variability. Variability is in the name. What is variability? It refers to the variation of the fetal heart rate from one beat to the next, and it is measured in beats per minute. Why does it happen? It occurs because of an interaction between the nervous system, chemoreceptors, baroreceptors, and the cardiac responsiveness. It's a very good thing, actually. Variability is important. It shows that the neuronal status of this baby is good. So it is a very good indicator that tells you that your fetus is healthy and has an adapting heart rate in response to changes in its environment. Normal variability indicates there's an intact neurological system. It can be characterized into three things. It can be either there's absent variability, there is minimal, or there is marked variability. Absent means it's undetectable. You're not seeing any changes in this graph. Minimum is 6 to 25 beats per minute, which is still good. And marked is anything greater than 25 beats per minute. Causes of decreased variability. Some cases, it could be as a result of mostly its fetal sleep cycles. We know that the fetal sleep cycle lasts between 20 to 40 minutes. However, if beyond 40 minutes, you're still seeing decreased variability, then this could indicate that maybe there's something else going on. There may be a cardiac anomaly, there may be hypoxia, acidosis, there's a CNS abnormality, or in some cases, prematurity. In the maternal side of things, it could be that there's an infection, there's fever, CNS depression, maybe the general anesthesia, or she's someone who has taken alcohol in the pregnancy, or certain drugs such as corticosteroids can also cause the same thing, such as decreased variability. This is another two graphs to represent to show what the difference looks like. If you can see in figure A, we can clearly see there's quite a lot of variability throughout the graph. Even if you look at the arrow where I've drawn the arrow, we have more than 25 beats per minute of variability. And if you look at the graph at the bottom, the arrow is literally so compressed. There's little to no variability. It's almost absent. So this is just a graph to help you differentiate between what variability, when it's marked variability, and when there's absent variability. Moving on to the next one, A stands for acceleration. So what is acceleration? It is an increase when there's an abrupt increase in the baseline fetal heart rate of greater than 15 beats per minute, lasting for greater than 15 seconds. The presence of acceleration is also a good sign. It means that the baby is reacting, the baby is moving, because the movement is what causes the increased heart rate. So it occurs alongside uterine contractions always, most sometimes, yeah, and it is seen in a healthy fetus. The absence of accelerations in a CTG is of little significance. It's not really that important. If they're absent, it's fine. But if they're there, it's good. The return to baseline is important to happen within 2 minutes. If it is anything that takes longer than 2 minutes to less than 10 minutes, it is prolonged. Oh, yeah, we have a graph over here at the bottom to just indicate that. Here we can see there's accelerations on the top. Yeah, we have 3 accelerations. Decelerations. This is the important one now. Again, remember the keyword is 15. The key number is 15. Decelerations is an abrupt decrease in the baseline fetal heart rate of greater than 15 beats per minute, lasting for greater than 15 seconds. The fetal heart rate is controlled by the autonomic and the somatic nervous system. It happens in response to hypoxic stress. What happens is the fetus reduces its heart rate to preserve myocardial oxygenation. To make this easier, let's look at this diagram. Okay, let's break it down. We have hypoxia. Because of hypoxia, what does an adult do? How will an adult compensate? What will they do? There is reduced oxygen, so they increase their respiratory rate to increase their oxygen supply. A fetus cannot do that. They're not using their lungs. They cannot just increase their respiration rate. So as a result, how would they compensate? They decrease their myocardial workload. So what do? They decrease the heart rate to preserve this energy. When the myocardial workload decreases, what happens? As a result, you're decreasing the heart rate. The decreased heart rate reflects as what? A deceleration on the graph. And this causes this. So you have oxygen now being conserved, less oxygen used by the heart, more oxygen now being sent to the brain and the other vital organs. Now, if this doesn't work, the fetus conserves more energy by not moving. So when it's not moving, there is no accelerations on the graph. So again, you see no accelerations now. If this still isn't working, as the hypoxia is progressing, what happens as a result? The fetus starts to release catecholamines. What is the role of these catecholamines? They help to increase the heart rate so that you can get more oxygen from the placenta to the fetus. Other than that, it also does peripheral vasoconstriction. So what does this do? This diverts the oxygen to the vital organs. And lastly, what it does, it breaks down the glycogen to glucose. In all these scenarios, if let's say they continue to do this, at some reduced oxygen to the brain, the heart rate goes down. And then nextly, is myocardial hypoxia and acidosis, which causes an unstable baseline pattern stepwise. And this is also known as a stepwise pattern to death. To make it easier to remember, just remember the mnemonic A, B, C, D, E. So what happens? Hypoxia begins with decelerations as a way of saving on that oxygen. Accelerations disappear to conserve the energy. The baseline fetal heart rate first increases. Then there's compensated stress. There's decompensation. And then at the end, there's end stage, which is the pattern to death. With that, this will make things a bit easier to understand. So we said in response to hypoxic stress, the fetus reduces its heart rate to preserve the myocardial oxygenation and perfusion. Unlike in adults, they cannot just increase their respiratory rate. So they need to have other compensation mechanisms. In decelerations, we normally classify them into 3 types. They can be an early deceleration, they can be a variable deceleration, and they can be late decelerations. In early decelerations, it is when they're associated with uterine contractions, i.e. they start when the uterine contractions start and they end when the uterine contraction end. I.e. it's a misnomer to name them early because they're not early, they are coinciding. It's basically when the trough of a deceleration coincides with the peak of a contraction. So what we call the mirror images of each other. It's due to an increased fetal intracranial pressure. So the increased pressure causes a vagal tone. It therefore quickly resolves once the uterine contraction ends and the intracranial pressure reduces. This type of deceleration is normally physiological and not pathological. Excuse me. So this is an image to help you understand what we're talking about. As you can see, the trough of the deceleration coincides with the peak of the contraction. This is early deceleration. Even here's another example down from a different graph. We can see we have 2 decelerations and both of them coincide with the peak of the contraction. Yeah. Next, we go to variable decelerations. What is a variable deceleration? These are observed when there's a rapid fall in the baseline heart rate with a variable recovery phase. Variable in the sense they're not constant, they're not consistent, they change, they have no relationship to the uterine contractions. They have nothing to do with when a uterine contraction starts or ends, and they don't coincide in any way. They're normally biphasic or double U-shaped. All fetuses experience stress during labor process. As a result of uterine contractions, there is reduced fetal perfusion. Whilst fetal stress is to be expected during labor, the challenge is to pick up any pathological distress. That's the main aim. Now, what happens in this case? The most common cause is umbilical cord compression. In this, what happens is you have the umbilical vein, and then you have, let's use this diagram, yeah. So in your umbilical cord, you have your umbilical vein, and then there are 2 umbilical arteries, and you have your Wharton's jelly. So when there is cord compression, the vein is the first one that compresses because it has low pressure, it has low resistance. Once that happens, it follows by compression of the umbilical arteries. So in the first part, when the umbilical vein goes down, due to the low pressure, this causes an acceleration in this graph. Then when the arteries get compressed, this causes a reduction in the fetal heart rate, causing this deceleration. After which, once the pressure has gone away, so there's recovery. So there's again an acceleration before the heart rate goes back to its baseline. So these 2 accelerations that occur is normally what we call shouldering. So it's caused due to cord compression. So when the vein is occluded, followed by the artery being occluded, causing this deceleration. What's concerning about this? If it lasts for more than 60 seconds, if there is no shouldering, so you don't see those accelerations, if there is a reduced baseline variability within the deceleration, and there's failure to return to the baseline heart rate. Here's a graph to help us understand this. As you can see, the deceleration has nothing to do with the contraction. It's okay, in this case, a little bit, but ideally, no. The main thing you can see is the shouldering is part of it. It is important and it's variable. So it's in the word, it's variable. The next one is deceleration, late deceleration. This is the concerning one. It is when the deceleration begins at the peak of a uterine contraction and recover after the contraction ends. This type of deceleration normally indicates that there is an insufficient blood flow to the uterus and the placenta. As a result, the blood flow to the fetus is significantly reduced, causing fetal hypoxia and acidosis. The causes of reduced uteroplacental blood flow include maternal hypotension, preeclampsia, uterine hyperstimulation. If you look at the graph at the side, it clearly indicates, as you can see, once the contraction is ending, there's the peak of the deceleration. Same thing for the other one. So this is late deceleration. Now that you know how to read it, you need to know the last part, your overall impression of your CTG. So that brings us to the last part of our mnemonic bravado. What is the overall impression? How are you going to categorize this patient? How are you going to intervene on this patient? In KNH, we normally divide this into 3 categories. So based on the CTG, you can have category 1, which is a no risk. Category 2, an immediate risk, or you'd redo, change the position, or anything basically that does not fall into category 1 or 3. And category 3, which is high risk, with need of an immediate intervention. So what do we mean when they say that there's no risk? A category 1 patient means they're ticking off the boxes in everything properly. Their baseline rate is normal, between 110 to 106. There is variability between 6 to 25 or more. There is no late or variable deceleration. There may or may not be early deceleration, and there may or may not be acceleration. And there's adequate contractions in a 10-minute window. What do we mean when we say that we have a category 2 patient? This means that the patient is intermediate. All tracings that are not categorized basically between 1 and 3 will put them under 2. Or what we do is if you have, let's say, 1 risk or 2 risk. Category 3, abnormal. You have an reduced fetal heart rate below 110. There's little to no variability. There is late decelerations, there are variable decelerations. You have inadequate contractions, or there's hyperstimulation that falls under category 3. This is also a sinusoidal pattern. We didn't talk about this in the other ones, but this pattern, this continuous pattern like this is sinusoidal, is referred to as a sinusoidal pattern. Very dangerous, needs immediate intervention, normally suggests, and it shows that there's fetal anemia, and it is not a good sign. It has the highest risk of mortality. Another way of classifying CTGs are using the NICE CTG classification. I've put this here so you can go through afterwards. I'll be sharing the slides at the end. This is another way of classifying it. Ideally, we don't follow this over here, but this is a good to know if you want to have a read on it, yeah? So let's do a bit of practice questions to understand whether we've seen the concept properly, okay? We have a 29-year-old gravida 1, para 0, 39 weeks with no antenatal complications. She's had spontaneous rupture of membranes and is currently at 4 centimeters of dilatation. Let's see, based on the history, is this a high risk or a low risk pregnancy? We see no complications, seems like everything is fine, so we categorize this as a low risk. Going to the C, contractions. If we look at a period of 10 minutes over here, we have approximately 2 to 3 contractions in a 10-minute window, which is good. Next, we go to the baseline heart rate. If we draw an imaginary line, ignoring the accelerations and decelerations, we can see that the approximate average fetal baseline heart rate is at 130 beats per minute, which is good, falls under the 110 and 160. Is there variability? We can clearly see there's variability throughout the graph of more than 25 in most places. So we're good. There is marked variability. Is there any accelerations? Yes, we have multiple accelerations. Are there decelerations? We do have 1 deceleration over here. And it's variable. We don't see any consistency over here. All the indicators are good, so we can say that this category 1 patient. Next, if we have a 35-year-old gravida 1, para 0, 41 weeks with induction of labor, there is no antenatal complications, there is artificial rupture of membranes, has 3 centimeters dilated, and is in syntocinon. Okay, let's look at the history. Do we see this as a high risk, low risk pregnancy? Technically, it's not very high risk, but she is on medication. She's on syntocinon, so we have a little bit of a risk. Let's look at the contractions. If we look at a 10-minute period window, we can clearly see there's an average of 5 to 6, and it's more than 5 contractions in a 10-minute window. This is hyperstimulation. There is tachysystole. Looking at the baseline heart rate over here. If we draw an average heart rate over here, this is 140, this is 160, comes somewhere in the middle, we can say that is at 150 beats per minute. Is there variability? Yes, there is variability, even of more than 25. Are there accelerations? Yes, we can see that there is one acceleration present here. Maybe. Yeah. Is there decelerations? Yes, we have multiple decelerations. Though, are they coordinating? Are they mirror images of each other's? No. They are variable. Are they late? No. But we have variable decelerations. Not the best indicator since we have 2 negatives. So we can say that this is normal. We can put this as a category 2 patient. We can probably repeat this CTG again after some time, maybe in a different position. Yeah. Going to the next part of our today's session, which will be normal vaginal delivery. To understand a normal vaginal delivery, you need to understand other composition, other parts of this. So we need to understand what a fetal lie is. Basically, a fetal lie is the position in which axis is this fetus, is the baby in. There are normally 3 lie we classify it into. Is it a longitudinal lie? So we remember from geography, there is longitude and latitude. So is it on a longitudinal plane? So longitudinal lie. Now we use our medical words. Is it on a transverse line? And is it crisscross? So oblique. The next we want to know is the presentation, which is the fetal body part that's presenting at the maternal pelvis inlet. Could be a cephalic presentation. It could be a breech presentation. It could be a face or a brow presentation. It could be a shoulder presentation, be foot link. So what part of the fetus or the baby is presenting at the mother's pelvic inlet? And why is this important? So that you can know if there's any other malpresentations, the face, brow, or any compound presentations. The position, this is the important one now. You want to know the relation of the fetal head to the maternal pelvis. How do we find out what position is where? You do this when you do the DBE. When the cervix is dilated, you feel for the occiput of the baby. The reference points are that the anterior fontanelle is a diamond shape, also known as a pragmatic fontanelle, and the posterior is a triangle, which is your lambdoid suit. So a posterior fontanelle. The most common position that we see is occiput anterior. Others include occiput posterior, occiput or transverse. And how are we going to do this? Let's look at this diagram for a bit of reference to understand this. This is the mom's spine, and this is the pubic symphysis. Your reference point is the position of the fetal occiput in relation to the mother. If the occiput is facing in front, we have occiput anterior. If it's facing directly behind, then it's occipital posterior. Then if it's on the right side, right anterior, right posterior, left anterior, left posterior. You must have seen in the notes, we have this compass-like thing. So this is basically what they're trying to show. What is the direction of the occiput in relation to the mom? Why is this important? Because it helps us in the delivery part of it. Next is the station. To understand the station, you want to know how far the bony presenting parts of the fetus have descended into the maternal pelvis. We normally grade it as 0 to 5, with 0 being at the level of the ischial spines. Anything less than that is now 1 out of 5, 2 out of 5, 3 out of 5, 4 out of 5, 5 out of 5. The equivalent of a descent is how many fifths above the pelvic brim. So how much of this baby has gone down? That's basically descent. Is it descending in the name? So the part of labor now, it involves 4 stages. Stage 1 is about the onset of labor. From onset of labor till you achieve full cervical dilation is stage 1. It's categorized into 2 phases. You have a latent phase and there is an active phase to it. Latent phase of labor is the dilatation from the 0 to less than 5, which is the 4 centimeter mark. That is known as latent stage. It is normally the one that's the longest and the hardest. If it is greater than 20 hours in a nulliparous woman, then that is referred to as prolonged. And if it is anything greater than 14 hours in a multiparous woman, then it is referred to as prolonged. Then in stage 1, the remaining part of the dilatation is referred to as active phase, sorry. So from 4 centimeters till achieving the 10 centimeters. Ideally, this is normally less than 12 hours in nulliparous. In multiparous, it's even faster. They normally progress at a rate of 2 centimeters in an hour. Stage number 2, which we are concerned with, which involves the period from full dilation to the delivery of the fetus. The average duration of this should be 15 minutes. Anything greater than 2 hours is referred to as prolonged. Navigation of the baby through the maternal pelvis. So the pelvis, if we look at landmark, if we divide it into planes, it has 3 parts. You have your inlet, you have your mid cavity, and then you have your outlet. And it is done in a series of steps, which involves engagement, descent, flexion, internal rotation, extension, external rotation, or restitution, and then expulsion. And now we'll talk about these in more detail now. The last stage are stage 3 and 4. Stage 3 is the interval between delivery of the fetus and the placenta. Averages of 10 minutes, anything greater than 30 minutes is prolonged. This part is important because this is the time where you want to pick out this PPH. And stage 4, if the first 2 hours after delivery, also equally important, or the golden hour, which we call in diagnosing PPH. Okay, so to understand this, let's break it down. We don't need to cram the movement of this baby. Let's try and understand it. If you look at the pelvic inlet, and if you look at the diameters of the pelvic inlet, let's do a little bit of anatomy. Where is the biggest diameter? The 13 centimeters we can see is in a transverse direction, right? If we look at the middle cavity, where is the largest diameter of 13 centimeters? It's in an oblique manner. And if we look at the outlet, where is our largest diameter? In an anteroposterior direction of 13 centimeters. So what is the whole part of delivery? We want the smallest part of the head to go through the largest part of the pelvis. And this is why we have the baby rotating. That's basically it. So how do we know the smallest part of the head? Ideally, when the baby's head is flexed, by flexed we mean it's towards the chest, we have the smallest diameter of 9.5 centimeters. If it's deflexed, like it's in a neutral position, the diameter increases. It's 11.5 centimeters. If it's a brow presentation, that's even greater, 13 centimeters. And if we have a face presentation, it is a small diameter of 9.5. But then why do we have a problem? Because the normal part of delivery requires the extension of the head. If the head is already extended, there is no further extension that's going to take place. So you will have, again, difficulties in this labor. Okay, so what's the best thing? We need a flexed head, which gives us a diameter of 9.5 centimeters. And we need this head to go in straight, then go in diagonally, and then go in vertically. So this is why we have the rotation. So why we started the start of in the pelvic inlet, it goes in an occipito-transverse manner. So it goes in horizontally. Then there is rotation because the largest diameter is in the oblique manner. So there is rotation. We have internal rotation. This then goes to the pelvic outlet, giving us a transverse vertical diameter of 13 centimeters. So this is basically why we're rotating and there is flexion of the head. So now we don't have to cram this. What is there? Let's go through the process again. You have engagement, where you have the greatest transverse diameter passing through the pelvic inlet, normally at station 0, which is your ischial spines. Now there's descent of this baby through the maternal pelvis. This is what we call descent. To do this, what does the baby need to have? The smallest diameter. To do that, what does the baby need to do? Flex the head. So there's flexion of the fetal head onto the chest, where the head meets resistance from maternal tissues. This allows for the smallest diameter of the fetal head to pass through the maternal pelvis. No more, rather than the biparietal diameter, which is longer, which is bigger. Next, we need the head to rotate so that it can meet the biggest diameter throughout the pelvis. So there's internal rotation. The head rotates the position, going into a final either occipito-anterior or an occipito-posterior position. When it gets then, there's extension. When it reaches to the vulva, the head needs to sort of extend. See, it extends so that it can push out. This extension will help the baby's head to push out. Once it's out, The head is rotated upwards, extension around the maternal pubic symphysis. But the baby's head cannot stay in extension. This is not a natural position. And we still have the rest of the body to come out. So what does it do? There is external rotation to meet the direction of the head of the rest of the body, and it goes back into a neutral position, which we call restitution. Followed by this is just the delivery of the shoulders. You have your anterior shoulder, your posterior shoulder, and the baby is out. Once that's out, it's followed by the placenta. Make sense? So don't cram this, just understand the process. You have engagement, and then there's descent to the maternal pelvis. To get the smallest head, you have flexion, followed by internal rotation so that it can go through the largest diameters. Then there's extension to get it out, but it cannot stay in extension. So it needs external rotation and restitution to get back into normal, into the neutral phase, and then expulsion. Other things to remember when you're talking about vaginal delivery is if there's retained placenta, anything greater than 30 minutes, you go for a manual removal or you do a controlled cord traction. Manual removal will involve you holding the uterus from the fundus on top, going inside the uterus with your other hand and sweeping, gently sweeping the placenta. So you're literally dislodging the placenta from the uterine wall and removing it. Gently do it. There are risk of PPH if done very quickly. Other include the controlled cord traction. So you pull the cord, hold the uterus from outside with one hand, and then apply continuous traction and gently pull the placenta out. Once it's out, what do? You examine the placenta. You're checking the membranes are intact. You're checking for any tears, any lesions in any cotyledons. You want to make sure that there's no parts of the placenta that are left behind. And once the baby's head comes out, another thing to do is to sweep the neck to make sure that there's no cord that's been wrapped around it. Remember to record and make notes about your delivery. Remember to do an outcome score on the neonate and look out for any mode loss in a spontaneous vertex delivery. Anything greater than 500 ml is concerning. Moving on to our next one, vacuum delivery. What happens in a situation where the normal delivery didn't progress or there were complications and it's not going as planned? So now you need to go in with reinforcement. You need to assist. But there are certain criteria for it. There need to be some prerequisites. Is the pregnancy greater than 36 weeks? Less than 32 weeks is a no for using a vacuum delivery. Is it a cephalic presentation? Is there full cervical dilatation? Is the fetal head at station 0? And is there descent of not more than 1 out of 5? Is the mom conscious, cooperative? Is there kaput? But there should be no molding. And do you have a skilled health worker? Very important. You need someone who knows how to do this. What are the indications of why do we do it? If there's a prolonged second stage of labor, you can say this mom is tired, she's not able to push, you can use the head is sort of stuck, so you go in with vacuum to assist. If this is a cardiac disease in pregnancy, because you don't want to increase the load on the heart. If it's hypertension, fatigue. So what is the process of doing this? Number one, obtain a verbal informed consent. If you can't get a consent, at least you get a consent and inform the mother what you're doing and why you're doing it. Put on your sterile gown and your gloves. Make sure your equipment is working. So what do you do when I say make sure your equipment is working? Place the suction cup on your hand and create a suction to see whether that suction is working. Next, you position the mother in a semi-lithotomy. Ask her to empty the bladder. Confirm that there's full cervical dilatation. So do a VE. Identify the posterior fontanelle and identify the sagittal sutures. Why? Because that will give you the guide on where you're going to place the suction. Assess for an episiotomy. If you feel like there's need and maybe an episiotomy will make it easier, go for it. Now, where do you place this cup? At a point that is known as the flexion point. What is the flexion point? It is 2 centimeters anterior to the posterior fontanelle. So 2 centimeters anterior to the posterior fontanelle is referred to as the flexion point. And you put this, it is along the sagittal suture. How do you put it? Stabilize the suction cup with 2 fingers using your non-dominant hand. Swipe to check that there is no maternal tissues that have come inside the cup. Create a vacuum of how much? Of 0.2 kgs per square centimeters. This is, you don't need to cram this. You just have to get it to the yellow mark on the vacuum, on the kiwi. Once you've done that, you do a second swipe to ensure that you have no maternal tissues that will come in again, before you now increase the vacuum pressure to 0.8, which is up to the green mark. Next, apply traction during a uterine contraction. Don't just keep pulling. When the mom says that, okay, I'm experiencing a contraction, during that contraction, she pushes and you pull. And this is done only perpendicular to the cup. As the baby's head is coming out, you move sort of in a J-shaped manner, going upwards. Once the head is out, release the pressure cup and release the pressure and then remove the cup. When do you abandon the procedure? Sometimes it's important to know when to stop as well. Fetal head does not advance with each pull. You've pulled 3 times, you're seeing no progress, abandon. There is no descent to the pelvic floor after 3 contractions and pulls. Despite after doing it, you've attempted 3 times, you see there's no progress. If your cuff slips off from the head 3 times, then end. Do not continue with the procedure. The complications from this are quite a bit. There is cephalohematoma, they can cause localized scalp edema, scalp abrasions, lacerations, intracranial hemorrhage. So it's important to not keep pushing. Like if it's not working, it's okay, let it be and move on to another technique. And for the maternal way, it can also cause lower genital tract injuries. This is quite a commonly asked question. So you have a diagram over here to explain. This is how we are saying we hold it with 2 fingers. And then this is the kiwi, has to be perpendicular. Pressure is given by pressing this. So you press that, create a pressure, create the vacuum. The parts of it, this is the suction cup, these are the distance markers, you have your vacuum indicator, and then the release button is at the other end, the bottom here. Okay. Going to the next one now, breech delivery. What about in a case of malpresentation? So breech presentation is when the fetus presents buttocks or feet first, rather than head first, like what we see in a cephalic presentation. Ideally, deliveries carry a very high risk of perinatal mortality and morbidity. It increases the risk of up to ×9 or ×10 even. And this is largely due to the fact of birth asphyxia, trauma, prematurity, and the increased incidence of congenital malformations. The diagnosis of breech presentation is of limited significance. It is if you diagnose breech between 32 and 35 weeks, it has little to no significance. Why? Because there's still a chance that this baby will turn at some point. However, if it's up to 37 weeks, it's fine. Beyond 37 weeks, the baby is still in breech, then yes, we can classify this as now a malpresentation or breech presentation. The types of breech presentation, they can be complete. Complete breech is when the baby is sort of sitting crisscross, like complete C, crisscross, like completely flexed. Both the legs are flexed at the hip and at the knees, so they're cross-legged. C, C. Frank presentation, when the legs are extended. F is like a tall letter, so you can just sort of like that. That's what I used to remember it anyways. So where both legs are flexed at the hip and extended at the knee. This is the most common type of breech presentation. And the next is foot link, where one foot has decided to just hang over there. So one or both legs are extended at the hip so that the foot is the presenting part. It's in the name. So in most cases and in practice nowadays, ideally, if you see a breech presentation, it is approached by doing a CS. It is normally not done as a vaginal delivery because there's a very high risk. However, in a situation where you're caught off guard, this mom has come with no ANC history, and she's already progressed through labor, and you need to do a breech delivery, you must ensure that you've confirmed this diagnosis. So let's go through the steps of how do we do it. Confirm the diagnosis. Ensure there's no contraindications to a vaginal delivery. Okay, call a consultant or a staff that's experienced to a breech delivery. This is very important. Don't go around trying this. Make sure you have someone who's experienced with you on the team. Also consider an episiotomy to increase the area that you're working with so that to make this process a bit easier. Ask the patient to lie at the edge of the bed in lithotomy position. In breech delivery, our best friend is gravity, and gravity is going to do most of the work. It is a hands-off delivery. You do not assist in this delivery of the baby until maternal efforts have resulted in the expulsion of the fetus up to the level of the scapula. Let gravity do its thing. what will happen is as the labor is progressing, the legs will be delivered spontaneously. Once the legs come out, just wrap a towel around the body of the fetus, okay? Pull a small loop of the cord down to prevent traction of the cord. Because in a normal delivery, if you look at it, the head comes out first, the body comes out, and then the umbilicus and the legs come out, right? So there's little traction between the placenta and the cord. In this case, if the legs are coming out first, followed by the umbilicus, there is a lot more pull on this. There's a lot more tension on this umbilical cord. So this is why you need to pull a small loop of it out. You don't want the placenta to start dislodging. So this is why you pull a little bit of the small loop of the cord to reduce the traction on this cord. Next, wrap the body in a towel to allow for support because they're very slippery and for good grip. Now, this is where you'll go in. You involve gentle rotation. We'll slowly deliver the arms. If not, then go in for Lofset's maneuver. We'll talk about Lofset's in detail there. Follow the humerus, come down, rotate each arm. So basically what you're going to do is go to the humerus, go down, rotate each hand inwards, and then from the chest, and then remove outwards. So you're basically scooping the arms from inside out, medial to lateral, medial to lateral. The aftercoming of the head may deliver spontaneously. If not, use the MSV maneuver, the Marcia-Smelby-Witt maneuver. The trunk of the body lies on the operator's right forearm. So basically what you're going to do is, see, we said that flexing the head is the smallest part. So basically now you're doing artificial flexion. You will be flexing the head of this baby to help get it out. So you have support to the shoulder. You have your other hand that's supporting the face of the baby and sort of flexing, and another assistant applying suprapubic pressure. This helps to flex the head to get it out. If the head is entrapped, uterine relaxation in theater may allow for the delivery. Complications of breech delivery. There's a lot of complications, and this is why it's normally advised to go for a CS. There could be cord prolapse, birth trauma as a result of extended arm or hand, incomplete dilation of the cervix, or CPD. Asphyxia as a result from cord prolapse or cord compression, placental detachment, or arrested head. There's damage to abdominal organs. They can cause a broken neck. And as a result, you're not only putting the risk of the fetus, you're not only putting the fetus at risk, even the mother is at risk. Documentation is very important. As always, have a detailed, clear, and comprehensive doc notes.
Hello, Tanvi. We can't hear you.
Hello.
Hello,
Yeah,
now
sorry. I think my network
now we
just
can.
went. The slides. What was the last thing that I was talking about?
You talked about documentation on the maneuvers just after the breech delivery.
And then, okay, perfect. No problem. Just a second. Let me just get my network to stabilize. Can you hear me?
Yes, loud and clear.
Perfect. Are we able to see the screen?
Yes.
Okay, perfect. So, sorry, where was the last part we were talking? I was on before I got
You talked
hindered
about
by.
the documentation part.
Okay, perfect. So moving on from documentation, yeah, it's always important to have a detailed documentation, counseling, identify all the problems that are involved, tell the mother of the risks of it, importance of ANC. And these are the two maneuvers that we were talking about. So this is just a diagrammatic image of basically what the MSV maneuver looks like. You're basically forcing the head into flexion because we know that flexion gets the smallest part of the head to present so that we can get the baby out. Okay. Moving on to the next one, which is shoulder dystocia. Shoulder dystocia refers to the situation where after delivery of the head, the anterior shoulder of the fetus becomes impacted into the maternal pubis symphysis, or the posterior shoulder becomes impacted at the sacral promontory. This is an obstetric emergency. To think of it like that, imagine if you're two people trying to get through a small door and both of you now are stuck. What has to happen? One person needs to step back and give way for the other one to pass through, because both are not able to pass through at the same time. That's basically sort of this. You have both your shoulders, but both of them are not able to pass through, and they're impacted over there at the canal. So the pathophysiology is basically that in normal labor, the fetal head is delivered via extension of the pelvic outlet. Remember the last extension that you have, and followed by the anterior shoulder, posterior shoulder. This is followed by restitution of the fetal head. So it lies in a neutral position in relation to its spine. This means the fetal shoulders now lie in an anterior-posterior position. When shoulder dystocia occurs, there is impaction of the anterior fetal shoulder behind the maternal pubic symphysis, and there's impaction of the posterior shoulder on the sacral promontory. A delay in delivery of the fetal shoulder can lead to hypoxia in the fetus, proportional to the time delay to complete the delivery. So it's very important to solve this as soon as you can. Applying traction of the fetal head is not advised because it can create brachial plexus injury. You can decapitate this child. It can cause severe neurological trauma. So what do you do? What are the risk factors? Why does this happen? It is mainly due to an increased fetal birth rate. Why does this happen? In maternal cases, if there's high BMI, multiparity, and advanced maternal age, diabetes, you're dealing with a baby which is more than 4 kilos, so previous macrosomia infant or excessive weight gain in pregnancy. Turtling is basically how, if you see a turtle, when the head comes out, it goes back in. So that's basically what we mean by turtle. So that's one of the warning signs of shoulder dystocia. So what is the management? You want to release the shoulders, release the entrapment. And the important part is to prevent fetal asphyxia and prevent Obs spouses any maternal trauma. Complications include PPH, lacerations, and in fetal cases, sometimes even cervical and humerus fractures, brachial plexus injuries, birth asphyxia, and in some worst case scenarios, even death. So how do we do this? Here comes our third mnemonic for the day, helper. Number one, call for help. There's always a mark for this. Always remember, in any scenario, call for help, okay? Evaluate the need for an episiotomy. Maybe giving an episiotomy will give you more room down there to help remove the shoulders that are impacted. Number three, L stands for legs. Do the McRoberts maneuver, chest knee position. P, external pressure, providing or putting suprapubic pressure to dislodge that anterior shoulder can actually relieve majority of the cases of shoulder dystocia. Actually, just doing that is enough to get the shoulders out. If not, then we start doing our maneuvers. So E, enter with maneuvers. Your maneuvers include the wood screw maneuver. You push on the posterior aspect of the anterior shoulder, and of the posterior shoulder, you try to rotate it. So if you've opened a wine bottle, you know how you rotate down? You're rotating to get the cork out. Basically, that's what you're doing. That's the wood screw maneuver. Or it's also known as a cork screw maneuver. So push on the anterior shoulder of the posterior shoulder and push on the anterior aspect of the posterior shoulder and try to rotate the shoulders in an oblique manner. R, remove the posterior arm. Grasp the fetal elbow, not the shoulder, and try and remove the arm out. R is to roll the patient. On her hands and knees, this position is called the Gaskin position. The gentle traction and gravity will, on the posterior upward traction, will help to sort of dislodge the shoulder. Ideally, this L and P, in most cases, these two will solve the problem. So when you ask, the macrobus position is basically asking the mom to bring the knees to the chest. When you do that, you sort of relax the pelvis area and it opens up the space. So it flattens the sacrum, and this can help to get the shoulder out. Further maneuvers include, or further interventions rather, include a cleidotomy, where you purposely fracture the fetal clavicle so that the shoulders become, the distance reduces, becomes smaller to get the shoulders out. Others involve symphysiotomy, involves cutting the pubic symphysis, like you actually go in and you cut. And otherwise Zanevelli, which involves returning the head back into the pelvis and now go in with a CS delivery. Ideally, these are rarely done or mostly never done. You use the maneuvers to get the baby out in most cases, because these are very trauma forms to do or to intervene with. Next is the corkscrew maneuver, the one that we were talking about. So basically, you apply pressure simultaneously in front of one shoulder and behind the other shoulder blade to move the baby in 180 degrees into an oblique position to sort of remove it out. Next, what are other complications that can occur in delivery? We have perineal tears that can happen. So episiotomy, sometimes you as a practitioner, you've created, you've gone in and you've done an episiotomy. So it's a surgical incision on the perineum performed to widen the vaginal opening to facilitate the delivery of an infant. It may be associated with an increased risk of extension to severe perineal lacerations, dyspareunia, and future pelvic floor dysfunction. So there is a lot of complications and risk that come with it. Types, there is midline and mediolateral. Always do it in, it's not recommended to go in straight down, like towards the anus. This is how you end up with like, those third-degree tears. So in this, some of the tears now, these are spontaneous perineal lacerations arising from perineal trauma as a result of delivery, and they're normally categorized as degrees from 1 to 4. If we look at the degrees, so you have first degree. First degree involves the perineal skin, the vaginal mucosal membrane, but it does not involve any of the fascia or the muscles. This is a nice diagram to represent that. So basically, it's just involving the mucosa and the membranes. It's not extended up to the level of the fascia and the muscles. So this is first degree. Second degree is when now there's involvement of the fascia and the muscles of the perineal body, but it has not gone to the anal sphincter. So this is your second degree tear now. Third degree extension is further, involves the external anal sphincter. It can be also further classified and broken down into 3. There's 3A, which is less than 50% of the external anal sphincter being torn. 3B, where you have greater than 50% of the anal sphincter now being torn. And 3C, where both internal and anal sphincter are torn. 3C involves the entire complex of the anal sphincter being involved. It's extended completely throughout the rectal mucosa. It's exposed to its lumen, and thus involves disruption of both external anal sphincter, internal anal sphincter, and the epithelium. So how do you approach this? We have to repair in layers. You don't just go in and stitch the outermost part. No, you have to go in, and this needs to be done immediately, by the way. So place an anchor stitch, find the wound, apex of the wound. From there, go in with an anchor stitch, close the vaginal mucosa and submucosa with continuous interlocking stitches. Then to close the vaginal incision and reapproximate the cut margins of the hymen ring using an absorbable suture, because you're not going to go back in and remove those sutures. Close the fascia and muscles to restore the perineal body using a continuous absorbable suture, either 2-0 or 3-0. You need thin, small sutures. Carry the continuous suture back upwards in a subcuticular stitch. Finally, tie the knot at the proximal part of the hymenal ring. Then post-op care is also very important. So pain control, educating on perineal hygiene, sitz baths, because this is painful. It's important even the diet is changed throughout this period. So she shouldn't, it's best to avoid anything that can cause constipation, anything that's going to put more pressure down there when she's passing stool. So should be having low liquid diet, rich fiber diet. Now, any recent tear that's happened, you've identified this patient as a tear, you need to go in and repair immediately within 24 hours. following the delivery of the placenta. Why? Because it reduces the chances of infection and minimizes blood loss. That area already has a lot of bacteria that's going on there. If you take longer than 24 hours, the repair is withheld. Why? You start now on antibiotics course because you need to prevent an infection. Anything greater than 24 hours is considered to be a contaminated wound, or because it's colonized with bacteria. So even if you go in and stitch that, you're not repairing clean tissue. You're repairing inflamed tissue that is not going to heal well, that is going to have very poor wound healing. So now you have to wait for 6 weeks approximately. So it's very important to identify these tears before the 24-hour mark. Actually, immediately go in and intervene. Otherwise, you're putting this mom through another 6 weeks of pain and discomfort. So what happens in this case? So you start them on antibiotics to prevent an infection, and then the complete repair is done after 3 months. Why? Because again, the stitching can become contaminated, the wound can trap bacteria inside it, leading to serious infections and wound breakdown or abscess. So instead, now you have to go in through the antibiotic route. It's very important, that's why I have to do it within 24 hours. In case of any doubt whether you don't know which one to classify a degree, if it's a first degree, second degree, third or fourth, always classify it as a higher one. It's advisable to always go up, then under-classify it. Complications include persistent incontinence of flatus and feces, and it's always recommended afterwards that once it's healed, once the tear is healed, to do physiotherapy for the pelvic floor muscles. Coming on to the last one for today, postpartum hemorrhage. I also know that we've already talked about this multiple times, so I'll just quickly revise through this. First thing, when you know there's a postpartum hemorrhage, identify the cause. Is it a primary or is it a secondary PPH? Next, you want to know what is the cause of this. Is it because of trauma? Is it there a tear that is causing this bleeding? Is it due to tissue that has been retained, or is it thrombin? Thrombin is normally not identified during labor. This is something that's normally done way before. Management, the important part that we're concerned with. Now we bring our next mnemonic and the last one for today, hemostasis. Remember this, literally just write it down and let's go with it one by one. H, call for help. Always remember, call for help. A, assess the vitals, resuscitate, provide any oxygen if needed, fix the wide bore IV cannulas, catheterize this patient, monitor your input and output, order blood, get your lab tests done, get samples for labs, do a GXM, start working on your tests, etc. E, establish etiology, start crystalloid therapy, start the blood transfusion. M, massage the uterus, fundal massage. O, start with oxytocin infusion if they've not already been done. S, there's still bleeding going on, shift to operation theater, start doing bimanual compression, put her on anti-shock garments to help have an outcome be a little bit better. T, identify it's a tissue, trauma, exclude whether it's tissue or trauma, and move on to the next T, which is the tamponade with a balloon. If this doesn't work, apply compression sutures, where you go in with your B-Lynch sutures. S, this still doing a B-Lynch suture hasn't helped, now you go in to cut the blood supply. So stepwise devascularization in order of the uterine vessels, followed by the ovarian vessels, and if that doesn't work, iliac vessels. I, if still we have not achieved, still she's bleeding, go in with interventional radiology and do an uterine artery embolization. And if we still have not controlled the PPH, our last option is to do a subtotal hysterectomy. You don't have time to do a total hysterectomy because your intention is to stop the bleeding. Now, the main thing we use is balloon tamponade. For those who have actually been in the theater and have seen a few PPH cases, you must have seen that they do this over here in KNH, where we do the balloon tamponade. How do we do it? Let's walk through the procedure of doing it. So it starts by you placing a condom over the balloon end of the Foley's catheter over here. Okay, it's okay. So take a condom and put it at the balloon end of the Foley's catheter. You tie the lower end of the condom snugly below the level of the balloon using a suture or a string. The tie should be tight enough to prevent any leakage of water, but should not strangulate the catheter to prevent any inflow. So it should not be tight enough that it's not allowing water to enter into the condom. Next, check for any leakage by inflating the balloon with around 20 cc's of water. Once you've identified you have no leakage, it's intact, go in and aseptically place the condoms high end into the uterine cavity by either digital manipulation or with the aid of a speculum and some forceps. Now inflate the condom tamponade by connecting the open outlet of the catheter, by a giving set, which is connected to an infusion bag, which has clean water in it. You can do this also with the aid of a syringe. Once it's done, cut the giving set at the end of the rubber to enable it to fit into the catheter. Basically, inflate the condom with water or saline of up to 300 to 500 ml, or up to there's no further bleeding being observed. Once that's in, clamp the catheter when the desired volume is achieved and when your bleeding is controlled. Maintain this tamponade in situ for the next 24 hours if bleeding is controlled and the patient has stopped bleeding and that the patient is stable. Once you've done that, start the patient on broad-spectrum antibiotics cover and monitor them closely. Treat or resuscitate or treat any other complications, such as shock or if there's any coagulopathies. So treat any of the other things that are there happening at the same time. Next, when the patient is stable, normally after 24 hours, you slowly deflate. And by slowly deflate, you're not deflating the entire thing. What you deflate is remove 50 ml of the water or saline every hour. If you see that the bleeding is still occurring, reinflate the balloon and let it be. And then try the process again after 24 hours. If the bleeding is not controlled within 15 minutes of the initial insertion of the condom tamponade, abandon this procedure, go in for a surgical intervention. If this is the first time when you're doing the tamponade, you've gone in, you've tried the tamponade, you've filled it to 500 ml, the bleeding has still not stopped, wait for 15 minutes or within 15 minutes of now doing this procedure, you now go in for the surgical interventions, which involve stepwise devascularization, interventional radiology, and in a worst case scenario, subtotal hysterectomy. Other things, the B-Lynch suture, which is also done quite frequently, by the way, in KNH. It is basically a compression suture, which is used to control severe postpartum hemorrhage. And when there is uterine atony, failure of this uterus to contract after delivery. Think of it as a belt that compresses the uterus to stop it bleeding without removing the uterus. Because in any scenario, you want to save the uterus. Your last resort is to remove the uterus. When is a B-Lynch suture used? So in severe PPH, which is unresponsive to uterotonics, if you have an atonic uterus, so it's soft and it's boggy, and if the uterus is accessible, so it's normally done in CS because in a cesarean section the patient is open. But in some cases, it can also be done after a vaginal delivery. It's severe. You don't want none of the tamponade is not working. The medications are not working. So now you go in with doing explorative laparotomy and you do a B-Lynch suture. Let's talk about how it's done now. To do a B-Lynch suture, you take an incision, so bite at the bottom of your uterine segment below where the cesarean section's incision was, 3 centimeters away from it. Then go out on the other side and bite again 3 centimeters away. Once that's done, you take the suture, go on top from the uterus, go behind over the fundus, go out and remove that bite again out into the uterus. Once you bit out again, go back in over here. Remove the suture, come back over the uterus and the fundus over here, come back over the uterus again, bite 3 centimeters above the incision site, go in from inside, bite 3 centimeters again away from the bottom of the incision site and come out. Next, ask your scrub nurse or whoever's with you to apply pressure on the uterus. Apply pressure and tie these. Upon doing this, the bleeding should stop. Once the bleeding has stopped, you go in with a continuous suture and you close your incision site. That's basically how a B-Lynch suture is done. Now, coming to the next part. Let's do some questions. I want someone to volunteer. Any volunteers? Amma, we pick. This is Obs scenarios. These are from our past papers. So can we have someone, or we have someone, can you guys respond? Maybe we can answer this in the chat if we don't want to. unmute ourselves. I can give you 2 minutes. Let's answer the question in the chat and then we can discuss this. Perfect. I can see a couple of answers for question 1, where we've said, what is the most likely diagnosis? So what's the scenario here? We have Acheng delivered 2 hours ago, and you have been called to review her because she's having heavy pervaginal bleeding. Excellent. The first answer is correct. We have primary PPH. What's the next step into managing this patient? Let's go. Let me give you another 2 minutes to type out your answers, and then we'll discuss this. That's good. We're doing well. I can see 2 answers. I'm sure everyone knows this. We are 4 weeks from end of years, or maybe 3. So I'll give you guys another minute. Perfect. I can see a couple of answers for part 2 as well. Excellent. Good job, guys. All of them are correct. It's just the order. So let's go through this step by step. The same way. Remember our hemostasis mnemonic. So again, you'll start always by, you've identified, we know that it's primary PPH. Identify yourself when you've come to the room. Tell who you are. To just introduce yourself to the patient if this patient is alert. Start by quickly doing an examination. You want to rub check on the fundus, rub to see if what the status of the uterus is. Next, demonstrate correct procedure, do bimanual compression, call for help. Get a small history of this patient or the pregnancy and the labor, because now you've just been called. You don't know what the status is. You don't know anything about this labor. You have no history about it. So get a brief history about the pregnancy and the labor. Examine the placenta, check that the placenta was completely removed and that there were no parts of the placenta that were left behind. You can do this, run the placenta under tap water, check that all lobes are intact. You have the cotyledons, the membranes. Yes. And now this is your general part of the management. I start your 2-bore IV cannulas, check the ABCDs like we had, I think someone had mentioned it. Yeah, Shem and Tracy had mentioned, call for help, do your ABCDs. Check for oxygen. If there's anything, send samples to the lab for cross-matching, start them on crystalloid therapy. That's basically it. Put in a catheter, monitor your input, output. This is all basically your general management. Check your pulse and BPs. Do a vaginal examination. Remove and expel all the clots inside your catheter. Again, this is all general. Now we go to the specific management. Yes, exactly. It depends on the 4 T's. So start by identifying which of the 4 T's is it. Is it tissue, trauma? Is it thrombin? So identify which, or is it toned? So once you've identified which of the 4 T's it's there, you start your management specifically. If it's toned, start on your oxytocin, start on massage. Next, go to your, if you see if there's any retained tissues that have caused it, so sweep in, make sure you've removed all the tissues. If it's thrombin or it's a result of clotting, get your blood transfusion, get clotting factors. And in worst case scenarios, now you go in, then going with the tamponade. If none of this is working, then B-Lynch again, if there's bleeding is still not been stopped. Next, again to the artery ligation of the vessels, and in worst case scenarios, hysterectomy. Remember, what's also important is post-op care. So post-op, they'll have the patient admitted in ICU or HDU, and it's always important to debrief the patient the importance of what happened, why it happened. If she's someone who's wants to have another child in the future, the importance of what she can do to prevent such a scenario happening again, and things that she can take care of. Yeah. Very good. Okay, on to the next scenario for today. You're called to review Josephine, who is in 2nd stage of labor with a malpresentation. Identify the malpresentation. Okay, for this one, I'll give you the hint. You've done Leopold's and you found out it's breech. Tell me the steps you do to conduct the delivery and the possible complications. Let's give you guys 2 minutes to answer this in the chat. Let's go. Or if anyone willing to unmute and maybe say the answer, they can raise their hand, and then Solomon can monitor and we can organize for that. Okay, I can see 2 answers. Excellent. Very good. I'm so proud of you guys. Confirm your diagnosis. Oh, we have a few more coming in. Let me give it a few seconds. Okay, let me give you guys a 30 more seconds. Then we discuss the answer. Perfect. Let's go over it now. What have we done? We've done Leopold's and we've identified the type of breech presentation. We've said that this is a breech presentation. Determines contraindications to vaginal breech delivery. So are they meeting the prerequisites to do a breech delivery? Explain to the mother about the diagnosis and get a consent. Determine the dilatation. Observe the no-touch technique. Yes, excellent, people. Yes, exactly. Hands-off technique. Let gravity do its thing. And then you go in with your maneuver. Make sure, remember to loosen the loop of the cord to reduce the traction. No touch until you see it's reached the scapula out of the neck. That's when you start applying gentle traction, support the baby, do your maneuvers. Make sure the sacrum and the baby's back is anterior. Deliver the arms by sweeping them across the chest and the abdomen and then removing them outside. The Loftus maneuver. Then do the smelly wheat maneuver or forceps. In our case, we don't use forceps in our scenario, so we'll ignore that, but you can write that for theoretical purposes. Avoid pulling on the jaw, remember. Understand the importance of keeping the head flexed in a mallow pressure. Check the delivery, check the baby after delivery, check the perineum for any tears, check the placenta's completeness. So all of you were right. Excellent. Very good job. What are the complications? Okay, now I've already given the answer here, so I'll just be like, what are the complications? Are birth asphyxia, umbilical cord prolapse, head entrapment, spinal cord injuries, limboclavicle fractures, dislocation of the hip, because these babies are small, and if you've seen them, they're so tiny, they're so weak, they're so easy to break of sort. Brachial plexus injury, intracranial hemorrhages, stillbirth, and in worst case scenario, neonatal death. And again, it's not just the fetus that's at risk, it's also the mom that's at risk because she can get perineal tears, there's need for episiotomy, there's need for PPH. There's possible PPH that can happen. Now on to the next one. Let's start with question number 1. Identify the equipment A. Sorry. Oh no. Just a second. Why did it do that? There we go. Okay, identify equipment A. And how will you manage this patient? So how are you going to use this equipment? I can see, yes, we've gotten that right answer. The first one is Kiwi. Very good, John. How are you going to manage this patient? Let's take a minute to answer. Let's be a little bit fast. Sorry, we're almost done. Hello, I'm sorry. Am I still audible? And is my screen being shared?
Yes, you're audible and we can see your screen.
Perfect. Okay, guys, let's answer. A couple of answers and all of you guys are correct. Excellent. I can see that we've all got it. Very good. So you're obtaining your consent, you confirm your equipment is working, position the mother, empty the bladder, confirm you have full cervical dilatation, ensure all the prerequisites are being matched, assess for a need for an episiotomy, place the center of the cup at the flexion point, which is 2 centimeters anterior to the posterior fontanelle, stabilize the suction cup with your 2 fingers using your non-dominant hand, swipe to check that you have no maternal tissues. Get to the pressure of 0.2, create your vacuum up to the pressure of 0.2, which is a yellow mark. Continue and swipe again to make sure, again, confirm that you have no maternal tissues. Then continue to create a vacuum until you reach 0.8, which is your green mark, and then gently push in a perpendicular direction when you have contractions. Maternal complications and complications, fetal complications are, fetal complications is they could be hematoma, localized scalp edema, abrasions, lacerations, intracranial hemorrhage. When it comes to the maternal side of it, they can cause lower genital tract injuries. Perfect. Now to the next one. We have a CTG here. We have a 38-year-old gravida 1 para 0 at 37 weeks of gestation. There's been induction of labor with in view of preeclampsia, meconium stained liqua, and is currently on 6 centimeters of dilatation. What is the name of this graph? Okay, we've already explained that, CTG. Explain this CTG using the Dr. C. Bravado method that we talked about, and interventions of this patient as well. Perfect. We've identified that it's high risk. Very good, Isaiah. What's the next part? Contractions. C. How many contractions are you seeing in a 10-minute window? We're seeing normal contractions of 4. Perfect. We're seeing 4 in 10 minutes, which is normal. What is the baseline heart rate? If you're going to draw, this is a bit tricky. Remember we said ignore accelerations and decelerations. Now what's the baseline heart rate? Excellent. Yes, we have 170 beats per minute. What is 170? Is that normal? Does that fall into our range of what the normal heart rate should be? We have tachycardia, exactly. Next, is there variability? Do we have variability? Of between 6 to 25, greater than 25, or we are seeing no variability in this graph? Is it marked, minimal, or absent? Minimal, yes. In most cases, it is minimal with a few where there's more than 26, maybe probably 6. Yes, exactly. What about accelerations? Are we seeing any accelerations? Are we seeing any accelerations? No, perfect, exactly. What are we seeing instead? Decelerations. Good. What are these decelerations? Are they early, variable, or late? If you have a ruler with you or a pen, just put it on the screen and see with each contraction and with each deceleration, are they matching? Are they late? Are they early? Are they variable? In most cases, yes, they are late. If you put a line through, you will see let me use my pointer just a second. If you draw a line, sorry, it's not straight, but in most cases they are. That was perfectly straight. Wow. Really good at this. If you can see, in most cases, they're starting, when is the deceleration? At the end of the contraction. So we have late deceleration. Overall, what is the impression of this CTG? Is this a category 1, category 2, category 3? We have a category 3 patient that requires immediate intervention. Do you think now in interventions of this patient, do we think that we're going to wait for another hour for her, another hour or 2 to deliver this baby via SVD? No, exactly. So what will be our interventions? Are we going to just wait and watch to see what happens? Or we put her in a different position and we do this CTG? Or based on what this CTG's findings are, what do you think our next set of interventions should be? What should we opt for in terms of delivery? What mode of delivery should we do now? Exactly, we would go for an emergency CS. Perfect, 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 very good. Okay, on to the last 2. Identify the type of suture. This is a really easy one and what it's used for. And we can answer this together. In the next one, I want you to label and tell me what each stage of labor are. What is 1, 2, 3, 4, 5, 6, 7 is? B-length. See, that's so easy. Distinction. Very good. B-length suture. What is it used for? What is the scenario that we use it in? To control PPH. Excellent. On to the next question. Please label the stages of delivery. Very good, very good. Excellent, guys. Very good job. So we have 1, 2, 3, 4, 5, 6, 7. I want you to write each number and what stage of labor we're talking about based on the diagram. Okay, I'll give you guys a minute to do this. Excellent. We get the first one at engagement. The second stage is descent. The third one is flexion. Perfect. Number 4, we have internal rotation. 5, we have external. 5 people. External rotation. No, we have. What happens to get that baby out? What does the head do? Exactly, it extends. There's extension, followed by external rotation, and lastly, then there's expulsion of the baby. Perfect. Good job, guys. With this, exactly here. I would like to tell you all thank you. And this, I come to the end of my presentation. I hope this was helpful and helped recap what we had done in Obs skills and different scenarios as practice questions to reinforce what we had learned. Thank you so much for your time and for still paying attention if you still are here, and for giving me your Saturday and as your Easter holiday. And now I think I'm going to hand over to my colleague Solomon, who's going to take you through a small Kahoot session. All right. Thank you so much. I hope you all enjoyed.
Thank you so much, Tanvi. It has been such an enlightening session. For those of us who did the Obs skills long ago, you've just reminded us of everything we need to know, and we are really grateful for such a well-detailed presentation. So without much further ado, we want us to do a small Kahoot session just for 5 minutes, and then we'll finish up. So let me just share in a bit.
Sorry, for a quick one. Those who asked me privately what the last stage was in that, it was expulsion. So now the baby's coming out. Okay.
Also, as we're doing the Kahoot, we can be having any questions. If you have any question, you can just post them in the chat, and then we'll cover them all after we're done with the Kahoot. So that's okay. So just go into the link sent in the chat by Felix and put in this code 2512873. Just 5 minutes. I'll encourage all of us to participate. It's just a fun thing to end the session. Thank you guys for coming in, and more welcome. We are at 10 right now. That's good. If you can get to 20, that'll be fine. Perfect. Thank you guys. Until 12:50. Then we start. So I think we can start now. We are 30. So I'll just okay, more coming in. 30 more seconds. So I'll lock the session so you can start. Nice. So the answer was Prom, and Cinderella is fast at the minute, but all of you guys got it right. Thank you. Uh, 31 people said Macrobus, that's correct. One person said wood screw, two people said love sets, and one said Morris Velvet. But the answer is Macrobus. The flexing of the legs. So Cinderella is still at top, and then followed by Tracy, and then Blah, and it's narrow. Let's see how it goes. I keep the answers coming in. A very easy question, just straight from the lecture. So Wasawa. So that one said complete, two said footling, and three said frank, but the correct answer is actually complete. So on the leaderboard, things have changed. So Tracy's up first, then Cinderella, then Tracy's twin. That's okay. Then Piastri has a streak with 3 correct answers in a row. That's good. Keep the answers coming in. Simple question. Nice. So the correct answer is actually external arm sphincter, and 26 got it right. 4 said perineal skin and muscle, and 2 said only the vaginal mucosa. The right answer is external arm sphincter because that degree. Cinderella is back on top, and Piastri is also following up next. Let's keep the answers coming in. Nice. So 25 of us got it right. The answer is hypoxia or CNS depression. 6 said reassuring status, but the right answer is actually hypoxia and CNS depression. 2 said active fetus, but no. Absent variability. We want a bit of variability to show responsiveness. Cinderella is still on top, followed by MSN, and Gingy is third. Let's keep the answers coming in. We're almost done. Perfect. So 31 of us said absent variability with current lead decelerations, which is the right answer. It's not about the early decelerations only, or about the tachysystole with accelerations. So there's a change in the leaderboard. So Blah is now top, followed by Gingy, then Tracy. It's a bit competitive. Let's see how it goes. 7 out of 11. Let's keep the answers coming in. Sorry, my connection dropped. Sorry, my bad. My connection dropped for a bit, but we can do it in the next. But the correct answer is actually variable decelerations. Let's just go to the next question. Sorry. So Gingy goes up first. I hope we are good now. Yeah, I think we are. Yeah, no, it's good. Yeah. Perfect. Everyone got this right, apart from Dre. But it's 2 centimeters anterior to the posterior fontanelle. That's the actually right answer, not 1 centimeter. But it's 2 centimeters anterior to the posterior fontanelle. Thank you, guys. So currently, Gingy is on top, then Blah, and Tracy. Let's see how it ends. Let's keep the answers coming in. So the right next step is to perform a offsets maneuver rather than use macrobats. Macrobats is for shoulder dystocia. So you perform a offset maneuver. So go on. So Trace is back on top, and then rice, and then coffee beans. So there's a change on the leaderboard. Thank you guys for your responses. So yeah, the next step will be to perform a reverse wood screw maneuver. Zavanelli comes way after, yeah? So let's see how it goes. So Trace is still on top, coffee bean is improved, and rice is third. So our final question. Nice. So as we've discussed, the next appropriate step will be to do a balloon turbulent insertion to control the bleeding, rather than to do uterine embolization and prostaglandin administration is not appropriate, but rather balloon turbulent insertion. So with that, we can see the final tally of results. And Chase's twin is actually third, Gingy is second, and up top is Drumlords is it's H. Yeah. Then there are the runners up. So if you H, you can unmute, say hi to us as we close off. That's okay. Kindly H.
Hi, it's Husseina.
Hi Husseina. Congratulations for winning.
Thank you, thank you.
You can look for me next week and I'll give you something.
Okay, will do.
So with that, I think we're done with the questions. So if there are any questions on chat, I'm trying to check if there are any questions on chat, but I can't seem to see any. So with that, I'll want to thank you guys so much for your participation, for your attendance, and I hope it's good revision for our upcoming examinations. And I wish you all the very best. Enjoy your Easter holidays. Thank you so much. You can now leave at your own pleasure.